Kia ora everybody, I hope you're all well. I wanted to do a YouTube video today on my interpretation of the use of the doctor's ABC algorithm in an arrest or a resus situation. I'm a registered nurse. I've been qualified for pretty far too long and currently hold a resus coordinator position in a hospital in New Zealand. The doctor's ABC algorithm works as well in the community as it does in a clinical situation, and it's one of the templates or algorithms that you train with so that when it gets in a situation you need it, you automatically use it as opposed to going to bits. For this brief look, I'll use both community examples and also template onto a more healthcare situations such as on the ward. So doctor's ABC stands for dangers, responsiveness, send for help, airway, breathing, start CPR or compressions, and attach defib. This algorithm works hand in hand with the chain of survival. This chain of survival gives the patient or someone suffering from a cardiac arrest the best chance for a best outcome, and it's recognizing the early recognition and call for help, early CPR, early defib, and post-resuscitation care. Really, the stuff that you do at the beginning of a resus, recognition, good quality CPR and calling for help, and early defib gives you the most chance for a successful resuscitation or return of spontaneous circulation. All the other sort of sexy stuff you do in a hospital, adrenaline, intubation, etc. It's good, but it's not as good as doing the first 3 or 4 parts of this chain of survival competently and well. Okay, so the first part of the algorithm is D is for danger. So if someone's arrested, it might just be the fact that they're arrested, but it could also be a more risky situation. They could be in a situation that puts you at risk. So you've got to consider the danger that may be present. Don't just go rushing into a situation because you've seen someone collapse. Remember that the chances there are that they're dead, and you don't want to be dead as well. All right, so don't move from being living to being dead because you think it's kind of something that you need to do. You need to assess the situation well before you commit yourself. So in a community sort of situation, someone can collapse sort of anywhere. But take for example that they've collapsed on the side of a road or in a car park. You've got multiple dangers that are potential. You know, cars coming in, other people, and it's not happening to them. The situation that you're in is happening to you and the patient or the casualty. So ensure that you're in a safe situation. If you're in a hospital, again, you need to assess what's going on. You don't want to put yourself or others in danger, so you need to scan the area before you go crashing in order to do your emergency treatments. So some of the dangers you may see out in the community if you come across a car crash. Vehicles crash in the open road all the time or within an urban area, and we're talking big speeds. All right, so come across a situation and you may well see petrol, oil, flammable liquids, also glass. If you kneel down on some of this glass, your patella tendon is not going to like it very much. So you've got to look all around for that sort of danger. Unexploded airbags are also a major risk. Modern cars have got multiple airbags, and having one of them going off at the side of your face as you're leaning to help a casualty will not mean you're having a good day. So again, assess that situation. Is the patient or casualty safer to be pulled out of the vehicle or treated as they are? And if someone collapses in a place such as a car park, remember, oncoming vehicles, other people, you've got to make the scene safe for you and the patient, but mainly for you, because like I say, you don't want to end up dead. In a hospital situation, there can be other sort of multiple dangers for yourself. So you can be wires, pendants, whatever on the floor, which you can trip up and hurt yourself as you're going in. There's nothing less heroic than rushing in to help somebody who needs it, and you've tripped up and hurt your back, and maybe damaged somebody else as well. Same in theatre. Now, the times I've banged my head on those low-lying theatre lights is not amusing. And if you're banging into some of those machines there, you're not going to have a good day. All right, so be careful as you go into the scene. The other thing with danger is danger to the patient as well, apart from the obvious danger of moving them from a risky area to a safer area, is the community. There's the medical team not doing what they are trained to do. For example, if you get 20 or 30 people coming in, which you could do if you're in a hospital and you push the come and help me button, lots of people will come in. Who's in charge? You've got lots of different people doing different things, and part of having the doctor's ABC algorithm is everybody is working off the same plan. They know there needs to be a team leader. They know people need to go to certain slots, such as airway, defib, compressions, and people work as an active team member or active followership in order to fulfill these roles. So it's very important there is a team, there's someone taking charge. So the danger there is people not doing their role properly, and therefore the patient not having the best chance to come out of the situation well. So you've made yourself safe, or safe as can be in a casualty. So the next part of the doctor's ABC is the responsiveness. So responsiveness is how conscious is the patient. Being unconscious is inherently bad. Unconscious, your tongue falls to the back of your mouth, throat, and your airway is blocked. And then a few minutes later, there's nothing can be done for you. So if a patient is quiet, is unconscious, they're most patient who is most at risk. So you've got to see how responsive or unresponsive they are. So the scale coming up with AVPU scale, where you assess the level of consciousness of the patient. So unconsciousness isn't just awake and unconscious. There can be various levels of it, and this is what you're looking for. So A stands for alert, V stands for responds to voice, P responds to pain, and U is unresponsive. The further down that scale you are, the worse condition you're in. So A is for alert. Is the patient or casualty alert and aware of what's going on? And then move to V, or verbal stimuli. Are they responding to your voice? And then P, painful stimuli. This is just a little pinch the ear, do a trapped T squeeze or a Mr. Spock on the shoulder, or press the capillary bed. Don't do or steer away from doing the sternal chest rub, as it's very stimulating, and after a short while you get a huge bruise. Another way to look at it is as you approach the patient, use your inside voice. Hey mate, are you all right? Outside voice, a bit louder, a bit shouty, and then a little bit of a painful stimuli to see their level of consciousness. Just another way of looking at it. If they're unconscious, any stage of unconsciousness, then that's bad because their airway is at risk. It's at this point that you need to send for help. You've ascertained the fact they're not just having a bit of a nap in the park. You know that they're in trouble, and you don't want to do this on your own. You want to share the love, make sure you got other people coming in, other people with skills and equipment to help you. So send for help. In a community, have a look at the crowd that's gathering around you, and pick a person from the crowd. So you want to get a relationship going with that person. I mean, I'm not talking a sort of a quality social relationship. You're not going to go out with them afterwards, but a relationship that they want to help you. They want to help the person. So introduce yourself. Say, hi, I'm Grim. What's your name? Hello, Sandra. Do you have a phone? And then give them explicit instructions to dial 111 or 999 or 911, wherever it is. Ask for the ambulance service. State that a patient or casualty has collapsed, is unresponsive, and your location, and tell them where to. That once they've done that, to come back to you to confirm, because then you know people are coming. And then point to someone else in the crowd and say, can you go to the shop over there or wherever it is and go and get me an AED or a defib? The advantage of doing this is you're not task overloading one person, but you are going to ensure that someone's getting you an AED and someone is going for healthcare help. Remember, the AED, the sooner you get it, the more effective it is, right? Rather than waiting 10 minutes for the ambulance. If you're in a hospital setting, you'll obviously be pressing the red emergency buzzer to get you help from the team that's around. Now, you have to remember that this is just the team that's on your ward or in your healthcare setting. as opposed to the 777 or the emergency response team. In that case, you need to make a further phone call to confirm you're getting that outside help, either that next level of care. Because what you want is the defib. In a hospital setting, it will be more likely to be a manual defib, which does AED and manual mode, but this is what you want. The majority of arrests in a community situation are a VF or ventricular fibrillation arrest, which will respond to an AED. Okay, so now you have help on the way. You know the patient is unresponsive, and you can then start doing your formal assessment. So why have they collapsed? So the first thing to do is to assess the airway. So open the patient's mouth and have a look down the airway to see what's there. You're not moving the patient's head or neck at this point. You're just opening the mouth and seeing if there's any kind of blockage at all. So if the patient or casualty's got well-fitting false teeth, leave them where they are. If you take out well-fitting false teeth, the airway is very hard to control. Certainly if the false teeth are sort of halfway down the throat, take them out. If you see something that's easily reachable, again, take that out. Don't chase something around the back of the throat because you just push it down further. Once you're happy there's no blockage in the mouth, then this is when you need to open the airway. Remember, when you become unconscious, your muscle tone relaxes and your tongue falls to the back of the throat, blocking off the airway, meaning you can't breathe in if you want to breathe. So what you do, 2 maneuvers, there's the head tilt chin lift, which you'll do with the majority of patients. This is where you put your hand on the forehead as shown, and then your other fingers on the other hand are on the bone of the jaw, and then tilt the head, okay? If you suspect a neck injury, for example, the patient has fallen from height, then you would do what's called a jaw thrust on the right hand side. But chances of a collapse, a heart attack or cardiac arrest, you would just be doing the head tilt chin lift. Okay, so what this does is the tongue is attached to the jaw. So as you move that jaw up, the tongue will be pulled off the back of the throat, and if the patient can breathe, they will breathe. So in the illustration you see there, the tongue is fallen back and is blocking the airway completely. Like I say, no air will go in and the patient will be dead in a few minutes. However, with a successfully carried out head tilt chin lift, the tongue is pulled forward, and as you can see in that picture, an open airway will come. So once you've done that, you've now got to assess to see if the patient is going to breathe. For this, you need to adopt the look, listen and feel position, and listen for no more than 10 seconds. Don't just do a quick flyby though. This is your chance to partly gather yourself, because this is not a normal thing that's happening, and you need to give the chance for the patient to breathe properly. So put your ear right next to the patient's mouth, keeping them in that head tilt chin lift position, and counting slowly to 10 in your head. Look down their chest to see if there's any movement of the chest. Listen with your ear obviously next to the patient's mouth, and feel for any breath that comes from the patient. So you've got 10 seconds for this. However, be aware, there's normal breathing, so patient will start breathing, cool. There's no breathing, patient's not breathing, not good, but you can carry on to the next. And there's something called abnormal breathing or agonal breathing. So this is when up to 40% of the patient in cardiac arrest, the brain stem, which controls your breathing, hasn't quite worked out that you're dead yet. You will be, just now hasn't worked out. So the patient gasps. This gasping is not normal breathing and therefore needs to be ignored. If you put the patient in a recovery position, if you hear them gasping, then a few minutes later they'll be dead. All right, so well, they are dead, but you know, there'll be no recovery for them. So unless it's normal breathing, you carry on doing the next stage, which is compressions. Believe me, if the patient is deeply asleep or something and you start doing compressions, they will wake up and tell you to stop. Okay, what you do not do at this point is check for a pulse. All right, so if the patient is not breathing, the chances they will not have a pulse. Even if they did have a pulse and they're not breathing, shortly afterwards they will not have a pulse. So all you're going to be doing by feeling for a pulse is wasting time. If you feel for a pulse in the neck, then chances are you wouldn't find it anyway. If you feel for a pulse, radial pulse by the wrist, that tends to disappear when the blood pressure goes lower. So you will not find a pulse. So do not feel a pulse. It's just wasting time, because as we'll find out in the compressions discussion shortly, not doing good solid compressions is what gives the patients less chance of return of spontaneous circulation, or ROSC. So do not feel for a pulse. Move on to the next stage. And that next stage is compressions. So moving on to compressions. So what are you trying to achieve whilst doing compressions? Well, you're trying to do what the heart does, which is perfuse the two most vital organs with oxygenated blood. The two organs being the brain and the heart. So both of these are very sensitive to a lack of oxygen, and without the required amount, within 10 minutes, there will be no hope for return of spontaneous circulation. So if you do a good enough job of compressions, then you will achieve around about 17% of the normal cerebral blood flow of oxygenated blood to the brain, and 30% to the flow to the heart. However, this is if you do 100% quality compressions, and this is what you're aiming to do. And you'll do this if you follow the following instructions: correct placement of the hands, correct rhythm, and the correct amount of compressions per minute. If you don't do this, the patient's chances of recovering from the situation they're in are minimal, and you're not doing your role correctly. So placement of the hands is very important. So expose the patient's chest, and the position you're looking for is center of chest, lower half of sternum. So the heart is located just to the left of the sternum, so that's where you're putting the heel of your hand. Don't go down by the liver, which is the right hand side, or the left, which is the pancreas, because that's not doing any good. Center of chest, lower half of sternum is your aim point. And as you see from the picture there, you're compressing a third of the chest. So remember, you're trying to mimic what the heart does. So you're trying to make enough pressure in the chest cavity to push the blood up to the heart. If you go too slow, i.e. below 90, then you will not get enough pressure up to get the blood to the brain. And if you go above 130, then you're not allowing the blood to refill the heart, and therefore you won't get the adequate pressure. So the rate of the compressions, 100 to 120, is very important. The depth of the compressions is very important. A third of the chest. And the ratio, 30 compressions to 2 attempted ventilations. So again, the patient positioning, or your positioning. So you're leaning over the patient. You're using your weight of your body to press your arms down, which are locked with the elbows locked, directly over the left hand, the center of the chest, lower half of sternum. So your arms are being a piston. There's no point in doing a Shortland Street or any of those sort of TV shows of doing using muscles, because after 2 minutes of chest compressions, you will be completely bollocks. You'll be absolutely knackered, and if you're not doing it properly. However, you'll still be knackered and not do them properly if you're not in the correct position in about 10 seconds. So you must be in the correct position for the patient's benefit, for your benefit. So here we have a picture of what happens. So on the downward stroke, you're providing the systolic pressure, i.e. the pressure for the blood to reach the brain, and therefore oxygenate the patient's brain. And on the upward, you're doing the diastolic pressure, which is allowing the blood to come back to the heart and feed the heart with blood. Because what you're trying to do is, there's different phases of the arrest. With the first phase, roughly about 4 minutes, being the electrical phase. So this phase has the best ability of the defib that you're trying to source being effective in restarting the patient's heart. Remembering a defib is a heart stopper, and hopefully the sinus node will restart the heart. And by giving good quality deep compressions, you're trying to elongate or lengthen the time of this 4 minutes. And seen it before happening. If you've got good quality compressions, the defib will be effective, but only if someone does those deep, fast compressions. So you've done those 30 compressions, and then you need to move to 2 attempted ventilations. So Back up to the patient's mouth, head tilt, chin lift. The patient's got to be in an open airway position for these to be effective. And then 2 attempted ventilations. So what you're looking for, you're breathing in, you're looking for the patient's chest to rise, and then taking another breath, for the patient. Remember, these are attempted ventilations though. Don't be there trying again and again and again to get ventilation in, because the patient may well have a blockage, which is what's caused them to collapse and arrest. So it's attempted ventilations. If you don't get a breath in the first time, test and adjust the neck where it is at, and then try again. If unsuccessful, then 30 compressions, and then have a look in the mouth as you go up to see if you've dislodged anything. Take it out if you have, and again 2 attempted ventilations. Right. Ventilations are important. I know in a COVID situation that we've sort of steered away from that, the risk of infection, but especially places in New Zealand or non-urban areas, prolonged resuscitations are what happens. So if you're circulating with your good quality compressions, deoxygenated blood, the blood that gets to the brain isn't going to perfuse it, and therefore even if you do get ROSC, the patient's not going to do well cognitively, i.e. they have minimal brain function. So ventilations are very important. Compressions are more important, but ventilations are too. And I've met people who have recovered from having a target event, and the only reason that they are doing well cognitively is because someone ventilated for them. In a hospital or in a medical, we've got a medical professional, you can use a bag, vast mouth, or a Liddell ambi bag, and these give advantages as 100% oxygen, but mouth to mouth is effective as well. So as you're doing those 32 compressions, you've sent for help, you've sent for someone going to get the defib. So hopefully these 2 things are on the way. If someone else turns up, or someone else is a first aider or a fellow nurse on the ward, then they can help you in the resus and take over those vital positions, be it airway, be it whatever it is. But then the defib is on its way, and then you're on to the D of Doctor's ABC, which is attached to defib. So the most common rhythm or cardiac rhythm in the community is VF. All right, so if you get a defib in, you've done quality compressions, and you get a defib in and good time, then the chances are that you will be successful in converting this rhythm into a sinus rhythm or a normal rhythm. So here are the 2 shockable rhythms, VF and ventricular fibrillation, where the heart is, all the cells are doing their own thing, and ventricular tachycardia, where the heart is going so quickly that the ventricles on the left side can't fill, therefore it's not supplying the blood to the rest of the body. So these are the 2 shockable rhythms, although don't shock on an asymptomatic VT, i.e. when the patient's awake, because they won't appreciate it very much. There's other things you can do. So this is what defib's trying to do. It's shocking the rhythm into something that puts out a pulse and supplies the body. Positioning of the pads is very important. You want the shock to go from the right side to the left side, traveling through the heart. And if you haven't got the pads, the defib pads in the correct place, i.e. on the right, just below the right clavicle and under the left armpit, then it's not going to shock the heart, therefore it won't be effective. There are different positions you can have. If it's a child or an adult, you can put them on the front and the back of the heart, which is a more efficient way of doing it. However, for an adult, it's very hard to do unless you've got a team of people. So there's no point, if you put the pad too low, you're going to shock the pancreas, not good. You've got to put it in a correct place in order for the shock to be effective. And you've also got to do a number of other things, such as ensure there's a good connection between the skin and the pad of the AED defib pad. If you've got a hairy person, they need to be shaved. If they've got a wet person, either they've drowned or they've got that sweat on you get before you collapse, they need to be dry in order to have that correct thing. If they've got some metal in there, like a port calf on the right hand side, you need to avoid that. Most pacemakers are on the left, so that's easy enough to avoid, but it's got to have connection. Breasts, lift them up, get them out of the way, put the pad under the left armpit. The shock doesn't travel well through the pads in adipose tissue. Bra, cut it off, get it off, whatever it is, put the pad with connection to the skin. Dignity is important, but being alive is even more important, so get that pad on. And then With the defib, you'll get a long, elongated talk saying things like, calm down, take a deep breath, loosen clothing. You know what to do. If the defib isn't analyzing or telling you to shock, someone is doing compressions. You're not pausing, you're not waiting, you're doing 30 to 2 compressions up until the point the machine is analyzing, which you stand back. Remember to stand back, because if you don't, it won't analyze correctly. Or it is charging and you're waiting for it to shock. Once the machine is charged, then press the shock button, shock the patient, and immediately start compressions again. It's been shown that a 10-second pause is detrimental to the patient's success rate when it comes to converting to a sinus rhythm or normal heartbeat. So the least amount of pause, the better. So crack straight back on with the compressions. And there you have Doctors ABC, the basic life support. I hope this was helpful. This talk is mainly being about adult basic life support, or Doctors ABC. Pediatric or child is in itself a whole different session. It's basically the same but different, as most things are. And the healthcare providers will use the more advanced advanced life support algorithm, which you can see at the moment, which has got some basic differences in it, more advanced stuff. But again, the doing well of the recognition, calling for help, and good quality CPR with the early arrival of an AED will do the most for the patient. Okay, well, thank you for listening, and catch you later.